Hello, everyone. My name is James Callahan from the Michael Garron Hospital IPAC team. I want to thank you for joining us today and to welcome you to another LTC CIP prep group lecture. Today, we have Bryan Morales and Michelle Alexander presenting the fifth lecture in our series, Prevention and Control of Infectious and Communicable Diseases. Bryan is a registered nurse with over 25 years experience, 20 of which have been devoted to IPAC. He holds a Master's of Science degree in Infection Control from the University of Essex, and he played a leadership role in the General Internal Medicine Unit during the SARS outbreak in 2003. Shortly after, he decided to devote his career to IPAC. Michelle brings 11 years of infection control experience and has obtained her Master's of Public Health from the University of Essex and is a certified clinical research coordinator. Her areas of focus was mainly endocrinology. Michelle also sits on the Research Ethics Board for Lakeridge Health. Both are certified in infection control. Bryan is currently the Senior Manager for the Infection Prevention Control Program supporting Lakeridge Health in Oshawa, Ontario, and Michelle is the Manager of the IPAC Hub at Lakeridge, where they both share their expertise to many long-term care and retirement homes in the surrounding community. And with that, I'm very pleased to hand over the presentation to Bryan and Michelle.
Thank you, James, for that introduction. I'm just going to share my screen. All right. So thanks, everybody. We are going to be talking about prevention and control of infectious diseases and communicable diseases in this session for our LTC CIP prep course. So for our outline today, there is a couple of topics that we will actually cover. Hand hygiene, we'll talk about the key elements of the hand hygiene program. We'll also talk about standard and transmission-based precautions, and this includes what these precautions entail, injection and safety and safe disposal. Personal protective equipment, or PPE. We're going to talk about the appropriate use of PPE, including the selection, procurement, donning and doffing, and the point of care risk assessment, as well as the regulatory requirements associated with the PPE supplies. We also talk about food safety, including the safe food handling and the regulatory requirements, hazard analysis, and critical control point, resident immunizations, and the ancillary services, which includes practices required for podiatry, dental, and environmental services. So just going to advance the slide here. So we'll just get right into it, and we'll talk about hand hygiene. So for everybody, we do always recommend that the single most effective measure that can be undertaken to decrease transmission of an organism or healthcare acquired infections between healthcare providers, patients, and the environment is the use of hand hygiene. So hand hygiene is plain or antimicrobial soap or waterless alcohol-based hand hygiene products. So there is quite a lot of indications for hand hygiene after touching blood, body fluid, secretions, and excretions, before contact with a resident, immediately after removing gloves, after contact with a resident's environment, between resident contacts, before and after food preparation and service, and after using bathroom facilities. What we'll focus more on for this session is the 5 moments of hand hygiene. So here in Ontario, we do have 4 moments for our studying and our CIP prep. We definitely want to make sure that we are align with the APIC text, which does kind of promote the 5 moments of hand hygiene. So the first one is pre-contact, so before touching resident when approaching them. The second one is pre-cleaning, so immediately before performing a clean or aseptic procedure. And the third one is post-exposure, so immediately after exposure, risk to bodily fluids, and after glove removal. 4 is the post-contact, after touching the resident and when leaving their side. And the 5th moment is the post-environmental, so after touching any object or furniture in a resident's immediate surroundings and immediately after removing gloves. So there is 2 methods for hand hygiene. There is the hand washing, which is use of soap and water. We recommend whenever hands are visibly soiled. Healthcare providers should been in contact with C. diff spores or norovirus. This is where we do recommend hand washing over cleaning hands with alcohol-based hand sanitizers, and when preparing food. When we use alcohol-based hand sanitizers, we're looking at an alcohol percentage of 60 to 95%. And typically they're made with isopropyl or ethyl alcohol, but both are effective against microorganisms, including fungi. It's important to note that isopropyl alcohol is good to kill bacteria and ethyl alcohol is good to kill viruses. So the gold standard in 2009, WHO recommended ABHS as the preferred method for hand hygiene. It's proven to be superior and a rapid microbial effect. They reduce the drying of the user's skin, which can pose an infection transmission risk. It's more convenient, leaves minimal to no residue, and does not contribute to antibiotic resistance. Glove use is not a substitute for hand hygiene, and this is, what we've actually been trying to promote alongside is, not to use the extended use of gloves, and really making sure that we're good with our practices with our hand hygiene. So in terms of hand hygiene, we also are looking at a hand hygiene program within the facility. So things to be considered within your hand hygiene program is the skin and nail care should be considered, hand lotions and cream to avoid skin dryness and other attendant risks. And you want to make sure your facility has approved the lotions and creams that are being utilized because some may interfere with hand sanitizers. So ICPs should consult their long-term care facilities purchasing department to ensure products that they procure do not negate the efficacy of the hand hygiene products. So no artificial fingernails or extenders for caring for high-risk residents and wearing any jewelry of any kind. ICPs should also have procedures and policies in place and provide healthcare provider education and training about when and how to perform hand hygiene. So ultimately, the ICP is responsible for providing staff education, providing resident education where appropriate, advising on product selection, advising on dispenser placement, and evaluating staff adherence to hand hygiene protocols. The biggest thing too is part of the role is also helping with the selection of hand hygiene products. So when we're looking at the selection of hand hygiene products, you want to make sure they're cost effective. You also want to consider the smell, the consistency, the feel of the product on the hands and skin, the color, and the ease of lathering. So ICPs should invite other healthcare providers to help with the selection of hand hygiene products and proper location of where these alcohol-based hand sanitizer dispensers should be located. So taking a look to see if it's location inside the resident rooms for point of care, near the doors to help with your moment 1, 4, and 5, and not really beside hand washing sinks, so not to get it confused with hand washing soap. Another part of that hand hygiene program is the hand hygiene auditing. So there is a couple ways to audit your hand hygiene practices within your facility. One is through direct observation, one's through product volume monitoring, and the other one is an automated monitoring. So ICP should report results out and at work on multimodal strategies to improve hand hygiene practices and provide timely feedback and compliance and performance. So the selection of correct hand hygiene surveillance methods depends on the facility size, complexity, and available resources. So we're going to go to a touch point from our talk today about hand hygiene. So food handlers should use which of the following hand hygiene methods? A, alcohol-based hand sanitizer, ABHS only. B, either soap and water or ABHS. C, soap and water only. Or D, soap and water followed by ABHS. So the right question here is soap and water only. So this is one of those indications where we do prefer hand washing over using the alcohol-based hand sanitizer. So that is it about hand hygiene. I am now going to move on to standard and transmission-based precautions. So just to give you guys an understanding, here in Ontario, we use the language routine practices. For our studying for a CIP course, APIC uses standard precautions. They are equivalently the same. And sometimes you'll see the use of the word universal precautions. Universal precautions, standard precautions, and routine practices are all of one the same. But for the purposes of our studying, we are going to use the language of standard precautions throughout this slide deck here. So standard precautions applies to all resident care situations to reduce the risk of transmission for both recognized and unrecognized sources of infection. Assume that every person is potentially infected or colonized with an organism that could potentially be transmitted in a healthcare setting. So we utilize standard precautions when coming in contact with blood, body fluid secretions or excretions, non-intact skin or lesions, or mucous membranes. So we did talk about hand hygiene, but it is part of standard precautions. Again, in Ontario, we practice hand hygiene at the 4 moments, but for the purposes of our study group here, we do need to know that for our exam, we need to know that we're using the 5 moments of hand hygiene. We also practice hand hygiene before donning gloves or PPE, after coming in contact with blood, bodily fluids, secretions, excretions, contaminated items, after doffing PPE and gloves, between resident contact, and before and after food preparation. Another section that's covered under standard precaution is personal protective equipment. So there is, you can see here, there's 4 kind of outlined descriptions of PPE. So we'll use gloves when we contact blood or body fluid excretions, or contaminated items, when we're touching mucous membranes or non-intact skin, for contact with intact skin, when there's infection risks identified. The use of a gown is during procedures and activities, when the healthcare personnel uniform clothing may be in contact with blood or body fluid excretions or excretions. The use of an eye protection or face shield during procedures and resident care activity likely to generate any kind of splashes or sprays of body fluids and secretions, such as examples would be suctioning or tracheostomy care. And again, the mask is to protect us from any infectious agents in the healthcare provider's nose or mouth during sterile procedures, such as insertion of catheters or injections or in spinal or epidural spaces during lumbar puncture procedures, but also to protect from respiratory secretions. So just kind of put a side note here that, if we're dealing with respiratory secretions, we also may want to add on the use of eye protection. So as part of the personal protective equipment, this includes your gloves, your face mask, your respirator, your gowns, your eye protection. So the selection of PPE depends on the task that's being performed and the anticipated level of exposure. So this is what's called a point of care risk assessment. So PPE is also dependent on the transmission-based precautions or the enhanced-based precautions, which we'll get to later in the presentation. So IPAC and the ICP should be prepared to provide education or supplemental training if lapses are observed or reported, and play a very proactive role and provide initial and refresher training, as well as ensuring that there's appropriate PPE supplies available at your facility. So in accordance with the OSHA and the CDC, the ICP should be involved in determining what PPE is necessary. They should also be involved in and responsible for selecting and purchasing the PPE. Another part of their role is to be responsible for monitoring the PPE use, ensuring that they're readily available for the healthcare provider when they need it. So they should also instill a PPE training form. So when to wear PPE, what kind of PPE should be worn, how to don, how to doff, and adjust and wear each type of PPE, what the limitations of each PPE is, the care, the maintenance, the useful life and storage of PPE. So this includes understanding the expiry dates for the PPE, how and when to use the PPE, should be safely disposed of, and then the competency reassessment. So making sure that this PPE training is ongoing in your facility and no less than annually. So there's 3 primary reasons for using PPC in long-term care. One is providing resident care. The other one is cleaning and disinfecting the facility, especially the resident's room. And the third is cleaning and disinfecting reusable equipment, devices, and in the environment. So there are regulations for PPE, which is issued by the OSHA. There is the blood-borne pathogen standard. So this includes masks, eye protection, and face shields and gowns are mandated to be worn, again, at no cost to the employee when there's a risk of the employee to blood or body fluid. Maintain appropriate PPE, appraisal of PPE stock, quantity and quality, and selection and provision. Then there's the respiratory protection standard, which makes sure that relevant respirators, including N95s, and training in their use at no cost to the employee. There's appropriate fit test, and there's trained ICPs on how to use respirators, including performing proper seal or fit check tests when N95 is worn. So this is a table of NIOSH respirator and mask use guidelines, which is taken from the APIC text. But it's good to know the situation and when to use a surgical or medical mask and when to use an N95 respirator. So we do encourage that you reference this table as well. Also making note, during an aerosol generating procedure, which is known as an AGPs, ICP should make sure that they institute a policy of keeping the room door closed when nebulizers are in use or other AGPs, and appropriate signage would indicates what relevant PPE is to be worn during those procedures. So here's an example of donning and doffing. So this looks familiar to you. This is taken from CDC and is definitely something that you need to look to studying for your exam. So when we are putting on PPE, the first thing is to put the gown on. Then we would put our mask or respirator on, then our eye protection, which includes the goggles and face shield, and then gloves. Again, the biggest moment too is before reaching for any kind of PPE, we need to encourage that our frontline staff always do hand hygiene before touching clean PPE. Now, if we go to the doffing sequence, there is a specific way to doff appropriately. So this is the doffing poster. So you want to take out the most contaminated pieces off first, which would be your gloves, and then your goggles or face shield, your gown, your mask and respirator, and then you would do hand washing or hand sanitizing immediately after removing PPE. Now you'll notice that there are two other icons here for hand hygiene. And this is kind of as an extra aside, you definitely want to kind of remember the sequence for doffing for your exam, but for your practical application, we do always encourage that staff, when they're taking the most contaminated pieces of PPE before touching anything on their face, we do recommend that they do another moment of hand hygiene. And this is kind of to help that kind of lessons learned that we've seen with COVID and SARS when we had the use of respirators. So just a side note, but for your exam, you definitely want to kind of understand the sequence 1 to 5 in terms of the proper doffing sequence. So the key messages when donning and doffing: keep hands away from face, limit surfaces touched, change gloves when they're torn or heavily soiled, and then performed hand hygiene between steps if hands become contaminated, and immediately after removing all PPE. So another part of PPE is the disposal. So you want to dispose once, it's used before leaving the patient's room in accordance to national and state standards. After providing care or cleaning, the N95 respirator should be discarded after leaving the room. So during times of national shortages like the COVID pandemic that we all experience, there may be local or state federal guidelines and regulations that may change to allow the reuse and extended use of certain PPE. Designated containers should be placed for doffing PPE by the doors of the resident's room. And reusable PPE should be placed in dedicated receptacle and disinfected as soon as possible. So should not be stored in personal lockers or removed from the facility if you guys are using reusable PPE at your facilities. Again, need to emphasize the importance of hand hygiene as a final step after removing PPE. So when you're evaluating PPE, there's 3 factors to keep in mind. You need to evaluate the availability, the accessibility, the storage, and correct use. So here's an example of the PPE supply evaluation. ICP should utilize electronic tools for tracking PPE and design an appropriate surveillance checklist for use of their facility. So CDC has some great resources in terms of a burn rate calculator and some of these tools that the APEC references. All right, so that concludes our PPE presentation. So we're just going to do a touch base point here. So what agency is responsible for the respiratory protection standard? A, Environmental Protection Agency, EPA. B, the National Institute of Occupational Health and Safety, which is NIOSH. C, Occupational Safety and Health Administration, OSHA. Or D, Centers of Disease Control and Prevention. So the right answer here is the Occupational Safety and Health Administration. So they do have the 2 standards there, the bloodborne pathogen standard as well as the respiratory protection standard. Which of the following tools can help provide the infection control professional to determine how long their existing personal protective equipment supply will last? A, Occupational Safety and Health Administration Respiratory Standard Calculator. B, Association of Professionals in Infection Control, which is APIC's Healthcare Associated Calculator. C, CDC's Burn Rate Calculator. Or D, Food and Drug Administration's FDA's Hazard and Analysis Critical Control Point System. So the answer here is C, CDC's Burn Rate Calculator. Okay, so I'm going to now talk about injection safety and proper handling of sharps and linens. So the healthcare professional should always use sterile, single-use disposable syringe and a needle for each injection given. Must remain free of contamination, and sterile packaging should only be opened immediately prior to use, and the vial access diaphragm should be disinfected with an approved antiseptic immediately prior to accessing. Single-use vials are always recommended over multi-dose vials, especially when administered to more than one patient. This is to help decrease the risk of the solution becoming contaminated due to multiple access. So injection safety, used needles should never be recapped, bent or broken, and any of the safety devices should be engaged immediately after use. And if recapping is necessary, again, one-handed technique should be used. Proper handling of sharps. All sharps should be placed immediately in an approved puncture-resistant container that is designed for sharps disposal. Other elements of the standard precautions include resident environment. So here's where we want to make sure that we handle and prevent any transfer of microorganism, physically separate clean and soiled holding areas, wear gloves if we're handling any visible or contaminated equipment that we're removing from isolated rooms, and then performing hand hygiene. The healthcare environment involves routine cleaning and disinfecting of the environmental surfaces, any high-touch surfaces and common areas of the facility. If a contractor provides a service for your home, for construction or renovation, that they verify the processes for your organization, including procedures, chemicals, safety measures, and the cleaning schedule. Another part is the laundry. So need to make sure that, our staff know how to handle the laundry and linens accordingly that help prevent the transfer of microorganisms to others in the environment, that the soil linen is contained and they store clean linen so that it does not become contaminated. We did talk about sharps, again, the one needle, one syringe only, one vial rule, using the safety engineered products, the correct disposal of used needles and other contaminated sharps, and then determining the need of the PPE before using the needs and sharps injection supplies. The respiratory etiquette involves instructing symptomatic residents to cover their mouth and nose when sneezing and coughing, using tissues and disposing in a no-touch receptacle, performing hand hygiene after contaminated hands, and then wearing a surgical or medical mask if they're unable to maintain spatial separation. So again, here in our APIC text, it refers to spatial separation of more than 3 feet between beds if possible. Resuscitation, use a mouthpiece, resuscitation bag, or other ventilation devices to prevent contact with mouth to oral secretions. And then accommodation. If we identify someone who may need to be isolated, we need to consider a private room just to decrease that risk of transmission to others. They probably would likely contaminate environment, unable to follow instructions, does not maintain appropriate hygiene, or if there's a risk of acquiring infection. So here's a touch point question. A resident develops a productive cough and a temperature of 38.3 degrees. What is the first action that should be taken by the nurse caring for the patient? A, initiate droplet precautions. B, notify the IP. C, obtain a sputum specimen. Or D, ask the physician to write an order. So the answer is A. We want to initiate droplet precautions, and this is what's called transmission-based precautions, which we'll go to in the next couple slides. So just to understand, what's the difference between infection and colonization? So infection is your microorganisms in the body that are causing clinical signs and symptoms like fever, cough, or dysuria, where the organism has invaded the host. Where colonization, the organisms are present in or on the body or at a particular site, but they're not showing any clinical signs or symptoms to indicate infection. So why is it important to understand this? It's important to understand this because it's essential to help us in terms of the proper management of residents and long-term care facility. For example, when someone is infected, we tend to use standard as transmission-based precautions, and someone who is colonized, we could look at enhanced-based precautions, and we will go to that in the next slides. So transmission-based precautions, and what we refer to here in Ontario as additional precautions, they can be initiated by the physician, IPAC, or any member of the nursing team. So transmission-based precautions can be discontinued when the clinical signs and symptoms are resolved or according to a pathogen-specific recommendation, and they're a key component to prevent and control the spread of infectious disease. So factors to implement transmission-based precautions, you'll make sure that you have administrative support, infection prevention staffing, clear communication, clear policies and procedures, education, and the infrastructure. So here is the hierarchy of controls. Again, the least effective is PPE, going up to the most effective, which is elimination, which includes all of those factors that I had outlined in the previous slide. So contact precautions is one of three main transmission-based precautions. It prevents transmission of organisms spread by contact, like your antibiotic-resistant organisms, like your vancomycin-resistant enterococcus, MRSA, CPO, C. diff. Residents to remain in their room only and only leaving for medically necessary procedures, and the use of gown and gloves for PPE. And rooms should be cleaned routinely, which means and daily. Sorry. During droplet precautions, we're looking at basically preventing transmission of organisms spread by large respiratory droplets from coughing, sneezing, or talking, which includes influenza, rhinovirus, pertussis, group A streptococcal pneumonia, and having a spatial separation of 3 to 6 feet distance of transmission. Mask, eye protection, in addition to the use of gown and gloves, is used here based on PCRA for droplet precautions. And then remain in the room unless medically necessary reasons. Again, residents are to wear a surgical mask during these scenarios. Airborne precautions prevents the transmission of organisms that remain suspended in the air and travel great distances due to their small size. So we're looking at organisms like tuberculosis or, measles, smallpox, chickenpox, avian influenza. This is where you need a negative pressure room. So it's called an airborne infection isolation room, where you have that negative pressure. For PPE, you would need masks, which would be your N95 respirator and your eye protection. In addition, you could use gown and gloves based on your point of care risk assessment. So healthcare providers should be all fit tested for their N95 respirators when interacting with a resident on airborne precautions. Now, depending on the room, if it doesn't have enough air exchanges, there is a considered washout period if someone was discharged out of that room before we turn it over to the next resident. Again, residents are to wear a surgical or medical mask when they're mobilizing out of that room. So this is a little bit new for us in Ontario. We don't have enhanced barrier precautions. So enhanced barrier precautions is something that was introduced by CDC in 2019. It's to prevent the transmission of multi-drug resistant organisms. So it doesn't restrict the residents to their rooms. Gown and gloves are to be worn by the healthcare provider during high touch activities. So, if addressing wounds, regardless of MDRO, colonization, indwelling medical devices, or infection or colonization with MDRO. So high contact situations could be bathing, showering, bathroom assistance, dressing, changing clothes, wound or device care, or changing linens. So although we don't have this type of precautions in Ontario, we do technically kind of practice this already in our long-term care facilities. We have our patients on contact precautions for AROs, but again, they are not restricted to their rooms and they're doing most of their daily activities outside the rooms, but this is where our staff would perform, their point of care risk assessment and wear their PPE according to the activity that they're doing with their residents. Intensified precautions is when we use both standard precautions and transmission-based precautions fail to stop transmission of infection organisms. So they could be used for highly transmissible pathogens, so influenza or norovirus, or if we have a multi-drug resistant organism. So examples when we implement this is when we're cohorting infected or colonized residents, when we're dedicating staff to care for isolated or cohorted residents, when we're restricting a new admission or closing affected nursing stations, nursing units, increasing or enhancing environmental cleaning and disinfecting procedures, and performing active surveillance cultures. So here's a touch point question in terms of what we talked about. So which of the following types of transmission-based precautions is appropriate for a resident colonized with vancomycin-resistant enterococci? A, contact precautions, B, droplet precautions, C, airborne precautions, or D, enhanced barrier precautions? So the answer is enhanced barrier precautions. So if you picked contact precautions, your answer is not wrong. It is right. But again, this is an APIC exam. We definitely want to make sure that you are aware that enhanced barrier precautions is being utilized for someone who is colonized in long-term care for residents. So this would be the right answer for this exam. So it will be tricky. There will be questions that give you more than one right answer, but you have to pick the most correct response for this question. And that concludes my section of the presentation. I will then hand it over to Bryan Morales for food safety.
Thank you, Michelle, and thank you for that excellent presentation. So I have a couple of other topics that I wanted to talk to you today to just wrap it up. So next page, please. I'll start with the food safety presentation, and I kind of like separated it in terms of looking at it from the 3 C's and the 1S, where we want to ensure that the how we're preparing the food is safe for our residents. And it's all through the Food and Drug Administration requirement, who also outlined the hazard analysis and critical control point. So I had listed here in terms of things that needed to be looked into as we were safely preparing a clean food, safe food. So cleaning, ensuring that our hands are washed, and our workstation when we're preparing the food are clean as well. The ensuring that the cooking temperatures are met, ensuring that there's separation between foods so as to avoid cross-contamination. And going right back to when we know that there's residents that have developed signs and symptoms of gastroenteric, that we are also separating and segregating that way, and ensuring that residents are restricted when we do see some activities with regards to gastroenteric symptoms, to sort of like isolate the issue. And investigating when we have 2 or more cases. So I also listed in here in terms of the storage, and it's really important to note that, albeit I'm not going to really go into some of the numbers, but the thing to take into note here is that this all plays in terms of when we are performing the HACCP, or the hazard control hazard analysis critical control point. I did not list the steps of HACCP here in my presentation, but I'm just going to go through it fairly quickly. It starts with analysis of what the hazard might be. So looking to see whether at any point during the preparation and the delivery of the food, was there anything that was missed that might have been listed here. Looking at what some of our critical points. So did we store them properly? Did we cook them properly? What is the limit in terms of our storage? What is the limit in terms of our temperature? And then looking at monitoring our procedure in terms of what we've done it. We've done that as well. And then from there, if we are looking at hazards that might have been identified based on that, what are some of the corrective actions that we can initiate, and how can we verify those procedures are happening? So that can only be done by ensuring that we have an accurate record keeping. So it's really important that we ensure that the temperature logs are appropriately documented using a approved thermometer. So it's not something that we can just buy out of Amazon. It has to be a a thermometer that's approved for food safety that we use, and it's really important that we have that analysis as well. So if next page, please. So instead of like really going through some of the HACCP, I thought that it's more important to really look at what we do when we have a foodborne outbreak, and how do we investigate with regards to that. So really important to identify an outbreak when we have it. I mentioned already with my initial slide that when we do have cases that we immediately put some action into it, including identifying those cases and talking to our appropriate health department, and generating some hypothesis as to why the outbreak had happened. And then here's where it comes in terms of the HACCP and the critical control point analysis, including sending it to the lab for testing and looking at possibly what are some of the things that we might have missed when we were deciding that and looking at that. So things to just kind of like remember, are there products that have been recalled? Are there other sources of contamination that we need to consider, that we need to remove? And what are some of the processes that we need to revise in order to control the outbreak? Next slide, please. So here are some of the most common foodborne illness that we have that you can possibly see in the LTCs, and really at the top of the list here is the norovirus. Norovirus is one that's fairly common, and it's spread fairly rapidly. This is a very busy slide and a very busy sort of like a table that I'm not going to go through all of it, but just to keep in mind that these are some of the most common pathogens that we will see when we have foodborne illness, and what to expect if we're sending samples to the lab. So norovirus, Salmonella, Clostridium perfringens, which is also known as a gas green, but it's got a lot of the implications with regards to beef, poultry, and gravies that are processed or in process, not processed properly. So keeping in mind of that as well, and then the Listeria monocytogenes and Cyclospora as well. So some of the things that may show up in your studies as you're looking at your LTC CIP study guide are some of the most common pathogens when we're dealing with foodborne illness. Next slide, please. Touch point again. The question is, what regulatory entity requires the healthcare facility to purchase and prepare foods from an approved source? A, good manufacturing practices. B, Center for Medicare and Medicaid Services, or CMS. C, the hazard analysis and critical control point, and the FDA. So it's really important to really understand the questions here, and it could be tricky in terms of what they are asking. The reason why I like this question is that it's easy to just kind of like answer HACCP because it is what we use, and it is through the FDA, but really looking at the questions and really understanding what's being asked here. And what's being asked here is, what is the regulatory entity? And the regulatory entity is actually the FDA, or the Food and Drug Administration. Thanks. And now I'm going to go through the resident immunization, and this should be a fairly a quick topic as well. We all know that one of the best defenses against the transmission of vaccine preventable diseases is through vaccination. And I'm going to stress that it's the vaccine preventable diseases that we're looking at. So it's really, really important that we understand the vaccination program within LTC, particularly for new resident, and really understand that vaccination is for all ages and for all risk status. Although when we're looking at the LTC, we're looking at the LTC population. IP, which is the infection preventionist. I know Michelle had mentioned ICP. In Ontario, we use the term ICP, but in the US, and as you're writing the exam, you may come to term with the word IP, which is infection preventionist. And so in consultation with others in the like medical staff and administration in the long-term care. We'll establish measures and processes for up-to-date records and record keeping for administration of vaccination. Next slide, please. So here are some of the things that are really critically important in terms of the information that we need as we're looking at the vaccine and the vaccination programs. So number one, we need to know what type and the name of the vaccine. We need to understand the date that the vaccine was given to the recipient or legally to a legal party. We need to understand the name of and title of the healthcare providers that had administered the vaccine and the address of the LTC that's administering the vaccine and also the vaccine number and the lot number. But the real takeaway from this slide is to ensure that we know that the vaccine consent must be obtained, whether it is through the resident themselves or with it if it's to the legal guardian when the resident is cognitively impaired. Next slide, please. So here are some of the recommendations that you might come across as you're doing your studies. So influenza, we know it's annually. Pneumococcal is based on the age of the recipient, i.e. the vaccination history and some of their comorbidities that you need to be aware of. The shingles or the herpes zosters are 2 injection, 2 to 6 months apart. And then the DPT, the tetanus, diphtheria, and pertussis. You can have the DTaP, which is done once if it's not received as an adolescence. If not, they can also receive the tetanus and diphtheria only, which is done every 10 years. And of course, the new sort of like a thing that we now have is the COVID-19. Next slide, please. So touch point question, resident vaccine history has been reviewed and it is determined that the pneumococcal and Tdap vaccine must be offered, vaccine consent and the distribution of vaccine information statement, which is the VIS, for each vaccines are required. If the resident is cognitively impaired, what action should be taken prior to administering the vaccine? Is it A, obtain authorization from the LTC administration and the next of kin to administer the vaccine based on the guidance for overall resident safety? B, obtain authorization from the LTC administrator to administer the vaccine based on the guidance of the overall resident safety and prove the resident with the appropriate VIS. C, obtain consent from the legal guardians to administer the vaccine and provide them with the appropriate VIS. Or D, obtain consent from the LTC medical director to administer the vaccine based on the resident's vaccine history and provide the resident with the appropriate VIS. So before we go in and really look at the answers, it's really important to understand that when we have questions that are very long like this, that we are actually really understanding what the question is asking to give us the best chance in terms of answering these questions. And for this, it's C. It's obtaining the consents from the legal guardians to administer the vaccine and to provide them with the appropriate VIS. The temptation is to look at some of the other options and think that it might also be right. But again, we are looking at the most appropriate answer here when we're writing a test like this. Next slide, please. Here's a shorter question. Why should a healthcare facility have an immunization program? Is it A, to help protect against lawsuit? B, is it because it's a requirement for the facility? C, is it to provide protection from disease? Or D, is it to provide from vaccine preventable diseases? And the answer here is D, which is specific to the vaccine preventable diseases. Certainly, C looks like it's correct as well. But remember, we cannot prevent all diseases from vaccine, but we can certainly provide the protection from the vaccine preventable diseases. Next slide, please. And almost to the end, where I'm just going to speak about some of the ancillary services that we maybe we need to be aware of as we're supporting our LTC. First one is the podiatry care. Looking at some of the risk in terms of inadequate reprocessing of equipment, such as clippers and scissors, equipment thoroughly clean and remove all debris and then sterilize before using HLD. This is part of the principle of disinfection to ensure that we remove the debris first. Diabetic foot ulcers that are done in the outpatient podiatry, it's just really important to continue to have a good documentation of what is being done and what some of their processes are. Looking at some of the dust control measures and proper PPE and cleaning to prevent onychomycosis, which I can't pronounce. Uh, and then looking at some of the mechanisms of reporting for residents with infection post podiatry procedures. So this is really important to look at some of the record keeping, particularly looking at some of the skin organism that we might see, some of the staph, particularly some of the staph aureus or the methicillin resistant staph aureus, and HBV and others. So where possible, we would like to have a dedicated proper treatment spaces for our podiatry and observing and ensuring that we have a measure for adherence in terms of policies and procedures and ensuring that we have those checklists so that we can see what is happening with our LTC. Next slide, please. Going over to the cosmetic, nail, and hair care, similar to the slide that I talked about later on, looking at some of the disposable products, foot care, spa, and chemical usage, and using some EPA approved disinfectant to ensure that we are cleaning the equipment and the areas properly. And it's really important to note that the only service should only be performed within the scope of the assigned duties, as we don't want to have any errors with this purposes. And I think we talked about the PPE as well for individuals performing nail care. And lastly, wanted to just kind of like talk about dental care and some of the requirements for dental care. It's not necessarily something that you would do as an ICP, but some of the things to just really have considered. There are some regulation that require assessment for oral health for residents and on admissions, and then regularly as scheduled, and keeping a good record of that. Replacement of toothbrushes every 3 months, and the use of antimicrobial alcohol rinse to clean toothbrushes is also indicated, and communication between any of the external parties that such as dental providers and infection preventionists when and really looking at their policies and procedures to ensure that it's not contraindicated in terms of your own policies and procedures, and looking at the risk for residents and dental healthcare professionals with regards to the blood and oral respiratory excretion, including the reprocessing of the equipment and the proper water quality and sharps. Next slide, please. Just really going right back to dental care. Some of the route of transmission would be the direct contact. So this is healthcare worker going through to looking at providing the care, indirect contact via contaminated hand or aerosol generation. As with the procedure, there is a risk for aerosol generation. So just really important to understand that all of this risk for transmission could happen during the dental procedure and dental care. So listed here in terms of some of the possible way to transmit, including resident to healthcare worker to resident. I'm not gonna go through into this a piece here, but just to keep in mind that there's a possibility that it could go from resident to healthcare worker and vice versa. And then if we are not really paying attention to this procedure, this could be incidentally where the dental practice could go into the community through improper waste management and improper cleaning of the environment. Next slide, please. So question with regards to the ancillary service here, among other pathogens, what infectious organism has been associated with hot tubs and whirlpools? I know that this is not something that we had covered as I was talking to it, but the answer to this is, go ahead, the next one, is Pseudomonas aeruginosa. So really looking at what are some of the waterborne pathogens that are implicated when we have improper cleaning with hot tubs and whirlpool, and Pseudomonas aeruginosa is the waterborne pathogens. So if you have questions like this, take a look at what the question is asking and what is the most likely pathogen, and based on whether it's a waterborne pathogen. Next question would be, there is a contracted dental service to clean residents' teeth in the LTC facility. What should you as the infection preventionist observe during the procedure to reduce the risk of infection to dental personnel or to the residents? Is it A, that each dental service follows their own policies and procedures, or B, that the area used for dental services is cleaned at the end of the service day? C, that dental personnel wears surgical masks and gloves, or D, that the dental service is following approved practice and standard precautions? And the most appropriate answer for this question would be D, that the dental service is following approved practice and standard precaution. And I think that brings us to the end of our presentation, and we hope that you were able to learn a few things, and we wish you all the luck and fun as you prepare for your LTC CIP.
Great. Thank you, Bryan, and thank you, Michelle, for this really wonderful presentation. It's very clear to me that the two of you have a deep understanding of this content. And so this lecture was the prevention and control of infectious and communicable diseases. And if I could just highlight three things I really liked about this presentation is, one, you routinely highlighted the difference between the language that's used in Ontario and the language that you can expect to be confronted with on the exam. Number two was you gave questions that are going to be very similar to what's going to be presented on the exam. And I loved how you asked the listeners to think about what is the question really asking and how to find the correct answer. And then finally, so much of IPAC is focused on acute care, and I really appreciate the two of you bringing all of your years of experience and focus towards LTC, because the staff that work in infection prevention and control and long-term care and the residents who reside there really demand and deserve it. So thank you again, and thank you to everyone who devoted the last hour paying attention. I think you're one step closer to challenging your exam and achieving your designation. So thank you so much. Okay, goodbye.